Hello, and welcome to this DeSera Clinical Educations podcast. I'm your host, Mandy Murph, and today's episode features a discussion between Dr. Angela Weyand from the University of Michigan Health and Dr. Guy Young from the Children's Hospital, Los Angeles. They will be discussing new agents and evolving approaches to restoring hemostatic balance in patients with hemophilia. This episode is part of a larger educational program titled Clinical Focus in Hemophilia, integrating hemostatic rebalancing therapies into personalized evidence-based care. For more information on Drs. Weyand and Young and a link to the larger educational program, please visit our show notes for this episode. And now, let's get started and hear what the experts have to say about this important topic.
Hello, and we're really happy to be here speaking about hemophilia and the latest treatments in hemophilia. There's been quite a lot of changes. That's what we're going to be discussing today. When I started taking care of hemophilia, we really just had one option, factor replacement. Essentially, factor replacement was factor replacement, be it for hemophilia A or hemophilia B. So we were always talking about IV therapy. We're always talking about needing to put central venous access devices in younger children, in patients with inhibitors, even sometimes in adult patients. So it was all IV, and that created a lot of problems. It created problems of needing central venous catheters. It created problems with adherence. It created a lot of other issues. Even if you were adherent and everything went well, it created problems with the treatment burden. And so we've really entered a new era where we've got lots more options, but more importantly, we've got lots of subcutaneous options. Angela, start with emicizumab and tell us why it's so important that we have these agents.
When you first started, there was only factor, and I first started, and then very quickly we had our first non-factor product, emicizumab, which was really exciting, especially for inhibitor patients. And I think that's also where having different options is most exciting, right? In patients with inhibitors that we can't just use factor products for. So that was very exciting for hemophilia A. But then I think with that introduction, we were getting a lot of hemophilia B patients coming in and asking, like, we heard there's these subcutaneous options, or we heard there's options that we don't have to dose as frequently. And we really didn't have options for hemophilia B patients outside of factor. It's really exciting that now we have these rebalancing agents that target our body's natural anticoagulants. Luckily, especially within the pediatric population where people have a lot more issues with intravenous access. As you mentioned, people having to have ports placed, which bring all of the different complications. Having a major surgery, you can get, even our patients with bleeding disorders can get thrombosis, having to come in when you're having fever, all of these different things that really impacted patients' quality of life. But it's very exciting that there's subcutaneous options. I think it's very exciting that some of them allow much less frequent dosing than our factor products, where some of the factor products that our patients were on requiring multiple times a week dosing. Those have been huge improvements in the quality of life. And as you mentioned, like the treatment burden for our patients. I don't know if you want to talk a little bit about the three products that we now have available, but they're all rebalancing agents. So things where we're not replacing what's missing, but rather decreasing our body's natural anticoagulant and trying to balance that balance between bleeding and clotting.
One of the non-factor therapies is emicizumab that we mentioned earlier. It's only for patients with hemophilia A, and it's been around for quite a few years. So we're not going to talk anymore about that option. Really, today, I want to talk about the rebalancing agents with you. And so these include fitusiran, concizumab, and marstacimab. First, we have to discuss rebalancing. What does that mean? What the audience should understand is that these three drugs all work more or less in a similar general way, which is that we have inhibitors to coagulation. For patients with hemophilia, this is the way I think about it. They can generate a small amount of thrombin via the extrinsic pathway, factor 7, tissue factor. They generate a small amount of thrombin, but they cannot ever get to the full thrombin burst because they don't have factor 8 or factor 9. And part of the problem is the coagulation inhibitors. So tissue factor pathway inhibitor inhibits the factor 7 tissue factor pathway. And then we have antithrombin, which obviously by its name inhibits thrombin, but also inhibits other coagulation proteins as well. So essentially, we're in a situation where hemophilia patients can generate a small amount of thrombin, but it is immediately inhibited by these coagulation inhibitors. So one way around this is essentially to lower the levels, inhibit, block, reduce, however you want to say it, the levels of these coagulation inhibitors. So in other words, if we can block or inhibit the function of tissue factor pathway inhibitor, or if we can block or reduce the levels of tissue factor pathway inhibitor or antithrombin, then the small amount of thrombin that hemophilia patients can generate will then be able to feed back on itself and generate more and more thrombin, such that the thrombin burst that is needed to make a blood clot can happen. That's what we mean by rebalancing. We're essentially saying that the balance is off because we're missing a procoagulant protein, factor 8 or factor 9. If you think about it as a scale, we can rebalance by taking away something from the other side. So instead of adding factor 8 or adding factor 9, we can take away tissue factor pathway inhibitor, or we can take away antithrombin. And that's where that rebalancing comes into play. So think about 3 blocks on either side of the scale. You take 1 block off one side, you can rebalance it by adding that block back, or you can rebalance it by taking a block off the other side of the scale. And that's really what the rebalancing agents are doing. And when we say rebalancing agents, again, just to emphasize, we're talking about fitusiran, concizumab, and marstacimab. With that, let's maybe start talking about the products specifically.
All 3 products are only approved for treatment of patients 12 and older. Dr. Young and I both take care of pediatric patients, and there will be ongoing studies looking at younger patients. But for now, they're only available for 12 and up. And as mentioned, with rebalancing agents, they're targeting different things. So marstacimab and concizumab are both targeting the TFPI pathway, whereas fitusiran is targeting a different pathway with antithrombin, siRNA knockdown of antithrombin. The first thing people think about is thrombosis. And so that is something we need to be thinking about. But marstacimab, as I mentioned, targets TFPI. It's currently only approved, as I mentioned, for 12 and up, and actually only approved for hemophilia A and B without inhibitors. It is subcutaneous, as all 3 products are, and is dosed once weekly. And there have been multiple trials. Most recently, presented at ASH this year, there was a trial for inhibitor patients. These drugs, and specifically marstacimab in their inhibitor trial, it's compared the ABR against patients who've been on on-demand treatment. There was a huge decrease in bleeding in those patients, a huge decrease in their ABR. It was superior to on-demand treatment. What's also important in a lot of these studies that they're collecting is improved quality of life, right? More and more in hemophilia trials, we're incorporating quality of life assessments. And when I think about my patients, whether it's the patients years ago that got transitioned from factor to emicizumab, or now are thinking about these products, you can look at the ABR, and we always look at the ABR, and we love to see low ABRs, and that's super important. But you can have products that have identical ABRs, and we have so many good products now. We're so lucky where a lot of these trials, the ABRs are so low. And now I think that's the bare minimum, right? It has to be an effective product. But along with that, it's a very different thing to see an ABR that's very low in a patient who's having to do IV administration 3 times a week than it is to see a very low ABR in a patient who's able to do maybe a subcutaneous injection every 2 months. You can imagine kind of the impact on their life and the impact, at least in pediatrics, on the rest of their family's lives, where if their mom is having to help infuse the kid 3 times a week versus doing a subcutaneous injection a couple of times a month, that's a big difference. Then concizumab, also targeting TFPI. The difference with concizumab and marstacimab, they both are targeting TFPI. They both are subcutaneous, which is fantastic. The dosing is a little bit different in that concizumab, instead of being a weekly injection, marstacimab is a daily injection. And with marstacimab, there's no kind of drug monitoring or levels that need to be followed. But with concizumab, it is recommended that a drug level would be checked at 4 weeks. Sometimes in clinic, those are things that matter to patients. Do I have to come back? Where can I get that lab drawn? Am I going to have to worry about changing the dose? How do I know that my treatment is in the sweet spot, especially in hemophilia, where for so long we focused on factor levels? And you could say for a long time, and still there are patients and providers where they use like the PK data and they want to know this many days after prophy, this is where my factor level is. And I feel like I can go and do this activity. And we don't really have similar things, but we do have some drug monitoring for these medications. Do you hear that, Guy, that patients struggle with not having that factor level?
Yes and no. I think in some respects, patients will take a subcutaneous treatment and accept some of the facts that there isn't a specific monitoring to do or things like that. That's not a reason why patients wouldn't switch to these. I haven't heard that so much in my clinic. For all three of these products, they've all been studied in patients older than 12. Because they're rebalancing agents, they work in patients with hemophilia A and B. And because they are also not a factor product, they work in patients with inhibitors. Currently, all three are approved for 12 and older hemophilia A or B with and without inhibitors, with just one exception, which is that marstacimab is not yet approved for patients with inhibitors, but that study was completed, and I anticipate that it will get that approval fairly soon. So just keep in mind for the audience that currently marstacimab is not approved for patients with inhibitors. We do know that that's coming in the near future. So to keep things simple, thinking about these drugs as subcutaneous drugs, all three of them, for hemophilia A or B, all three of them, currently for patients older than 12, all three of them, and for patients with and without inhibitors once marstacimab gets that inhibitor indication. There are trials going on for children. It's going to be some time before these will be approved for children less than 12, so we won't really focus so much on that. As far as efficacy and safety are concerned, I do believe that these drugs are, generally speaking, effective to very effective, and they are, generally speaking, safe. There are, of course, risks with any such drugs. I encourage the audience to look at the prescribing information for all the details about the safety issues. Fitusiran, for example, is one that has a boxed warning for thrombotic events and for gallbladder issues. Compared to on-demand treatment, these were all highly effective, reducing bleed rates. Compared to clotting factor prophylaxis, all three of them were shown to be at least as effective, if not more effective than clotting factor prophylaxis in the trials where there was a lead-in with clotting factor. So I think what the audience should take away is that these drugs are effective at preventing bleeding. Now, one other point of emphasis, these are only for bleed prevention. So all the patients will still need a prescription for factor replacement or bypassing agents to manage bleeds. You don't give an extra dose of these drugs if there's a bleed, you then have to give factor. And that's kind of the general summary of the efficacy and the safety of these products. Talk about the implementation issues.
Sure. I'll just start with marstacimab. As I mentioned, there's no lab monitoring that's required. It is, as I mentioned, weekly subcutaneous injection with a pen device. I do hear things from patients or in the patient community that sometimes the device that makes a difference to patients more than I would have anticipated. All three pen devices, I should mention. And as I mentioned before, the marstacimab is the weekly versus concizumab daily, and fitusiran can be every month or every 2 months, depending on some of the lab monitoring. So for concizumab, there is a recommendation to check the drug level at 4 weeks. A proportion of patients do require a dose adjustment following that 4-week level. And so that is something that isn't just straight dosing. The patients would be started on a specific dose and then have that 4-week level. And then fitusiran, similarly, as mentioned, thrombosis is one of the things that we're all very cognizant of as far as a risk for these products, both from just knowing or treating patients with antithrombin deficiency or these sorts of things, but then also from the clinical trials. And fitusiran does have that box warning about thromboembolism, but they have a very nice mitigation strategy that has been put into place. Patients have baseline antithrombin levels ordered after each dose for this first 6 months after starting, and then also after any dose adjustments. And then based on what their antithrombin level is, their dose would be adjusted. Patients are started initially on every 2 months, but they may end up having to be every 1 month. That would be the most frequent. The majority of patients, at least so far, end up in that every 2-month range based on their antithrombin levels. So that is another one where there is some drug monitoring, there is some possibility and probably a good proportion of patients for changing dosage based on those levels versus marstacimab, where there isn't anything like that. I haven't heard a lot about that being a challenge for patients. For the people I've spoken with, it seems to be going pretty well. For concizumab and for fitusiran, that not being a huge issue in terms of the monitoring.
One thing to know about Marstacimab is that it is a flat dose. Everybody older than 12 gets the same dose. It doesn't matter what their weight is. And one other point, which is the first dose is a double dose. So it's 300 milligrams. You get 2 pens, one pen in one side of the belly or wherever you inject it, one on the other side. And that's how you start. And then after that, it is weekly. There is an option to double the dose for marstacimab. A small percentage of patients did double their dose in the trial, and that did seem to help. So if a patient's on marstacimab and they're having bleeding symptoms, that is an option, is to double the dose before you choose to switch them off to something else. Fitusiran is also flat dosing. So everybody older than 12 gets the same dose. And then, as you mentioned, the dose adjustments happen from there. And in the prescribing information, there's a dosing algorithm on the website. There is a way for you to input your patient's information, your dose, like an algorithm again, so you can figure out how to change their dose if needed based on the antithrombin levels, because we are targeting levels of 15 to 35%. And then with concizumab, that's one's a little bit different because it is weight-based. So the pen for concizumab has a dial in it, and then patients would dial their dose. And as you said, you have to get a lab test, and then based on the lab test, you may have to increase the per kilogram dose, or you may decrease the per kilogram dose, which obviously would change the full dose. They all come in these little pens, the marstacimab and fitusiran pens. So they're disposable. Use them once and you throw them out until the following dose. The concizumab pen is a dial pen, which is multi-dose. Depending on your dose, and there's different size pens. And again, on the website and in the prescribing information, there's a nice tool that you can use. They're interactive tools that can help you figure out which pen to prescribe for a patient. The pharmacies help us to do that. I just put the medication in and the frequency, and then they'll figure out, what size concizumab pen to send to the patients. So I think it is an important point about the monitoring. So as you said, marstacimab, no monitoring. Fitusiran monitoring for 6 months and then once a year once you get the dose right. And concizumab, there's a requirement to do one test, and then beyond that, it's up to you if you do more tests. As I think about the practical implementation of which patients might be right for one, I did recently put a patient on marstacimab, and it was an young adult patient. He wanted to switch to a subcutaneous drug. He didn't really have any specific inclination to one or the other. He was kind of relying on us. But one of the things that I learned is that he lives in a rural area, and the closest lab to his house is 45 minutes driving. And so that's when I started thinking, well, that's going to be a pain to have to do a lab once a month. The concizumab level is very unique in the sense that you have to go through a special portal. It's not something that can be done in sort of one of those commercial labs out there. So as I was thinking about him, I thought, well, I need to figure something out where he doesn't have to deal with the lab. And that's where marstacimab became the natural choice for him. Not that I felt that it would be any better or worse than the other ones. I feel like they're all effective and safe. But in terms of implementing, that's one thing to think about. So if the audience members who are listening to this podcast, if you work in a rural area, if you have patients from a rural area, certainly one consideration is the lab testing. For those patients for whom lab testing might be a challenge to sort out and figure out how to do it, that's where marstacimab naturally doesn't require that. The flip side, though, some patients like to know what their factor level is, and their doctors sometimes like to know what their factor level is. And so to me, one of the downsides of marstacimab is not only is there no lab monitoring, which is a good thing in many senses, but the flip side of that is that even if I want to do a test, let's say somebody's on marstacimab and they're bleeding and I want to, are they adherent? Are they not adherent? What's their level? There is no way to actually measure a marstacimab level or a TFPI level that's going to be accurate. So you're running a little bit blind with marstacimab. So the strength is its simplicity and ease, and you don't need lab monitoring, and people live far from a lab, fantastic. And I've chosen marstacimab specifically for patients like that. But the downside is there isn't something to test. So maybe I think, as you brought up the point about patients want to know and doctors want to know sometimes where patients are sort of with their meds, what do you think about concizumab and fitusiran, where not only is testing available, but it's required? The downside is it's required. We have to do it and we have to figure it out. But the upside is we have something where we know where patients are. So what do you think of that as a physician thinking about these three medications and that situation?
Yeah, it's a really interesting thought that, and I think even you saying that about someone living in a rural area, I was thinking to myself that patient previously was on factor, and maybe at times you wanted to get a factor level, and that wasn't necessarily available at a close lab to him. There's all these intricacies now to how we're measuring things, and that may not necessarily be available in rural places. It's interesting because there is that benefit for patients who want to know, and some of the elderly patients have bad joints, and it's not always totally clear that they're having a joint bleed versus long-standing joint damage that's causing them pain. Sometimes I think that would give either the patients or the providers a little comfort or reassurance that they could measure that and know that this is where it should be. I still think it's, far from where we were with factor levels, right? Where I think everyone had a lot more decades long experience, knowing factor levels, feeling more confident about if your factor level is X, that you could do certain activities or go to surgery or these sorts of things. Whereas I feel like if I get a concizumab level back, I don't necessarily have that same comfort level as like, okay, the factor is 100%.
We know that in hemophilia A, the majority of patients in the US are on emicizumab. And we know that emicizumab has a long washout time. It's 4 months minimum, 4 to 6 months for a full washout. So, how would one switch a patient if they are wanting to switch from emicizumab to one of the rebalancing agents? And there are patients on emicizumab who still have more bleeds than they like, but they don't want to go back to an IV therapy. There may be reasons why a hemophilia A patient, even if they're doing relatively well, might consider switching to one of these agents once they see the hemophilia B patient having these little pens where it's like, boom, I'm done in 30 seconds. They might be thinking about one of these drugs as opposed to what they have to do with the injections with emicizumab, which could be large volumes and they are relatively painful when you have to do them. We don't really have a way for you to switch. There are studies going on right now for patients to switch from emicizumab to fitusiran to concizumab to marstacimab. There's some very early data that actually I presented at ASH on just a few patients, 3 patients who switched from emicizumab to fitusiran. Too early to really make any good thoughts or suggestions. So for those of you who have a hemophilia A patient who wants to switch from emicizumab, I mean, one option is to let the emicizumab wash out over 4 to 6 months, but we don't love that idea because then they're open for bleeding. Another option is to pick some time after stopping emicizumab, say 2 months or 3 months, to then introduce the new medication. But, there's no data on that. So none of us can vouch for the fact of how safe that would be or at what point you would need to do that. So I think there's a bit of a challenge in switching emicizumab patients to one of these drugs until we have more information. You can take this on a case-by-case basis. And as I said, there are trials going on, and you want to look up the clinical trial and how they're doing it in the trial and mimic that. The switch from factor is pretty easy because, even the longest acting factors in about a week pretty much washes out of your system. So it's not too difficult to make the switch from factor if it's on a hemophilia A factor or a hemophilia B factor, factor 8 or factor 9. In terms of wrapping up, give us a couple thoughts on that as we get to close.
We used to have patients on factor, and if they were switching to a different factor, it was very clear how to do that. The products were working the same. There wasn't a lot of education to do because they were still going to be doing intravenous infusion. These products are very different. There are some centers that have been involved in the trials and have more experience, but all of us are starting with a lot fewer patients that we have experience with compared to what we had when everyone was on factor. What you were saying about the transition, if you're on emicizumab, the case-by-case basis is so important because I feel like we have some patients where I would worry more about overlap because they have other thrombotic risk factors. Maybe they're older versus other patients where maybe they're young and very healthy, but really are more tenuous when it comes to being at risk for bleeds. And so those patients, I really wouldn't want to be off things, and maybe I feel more comfortable with more overlap between the emicizumab and a new product. We're all learning. And I think reiterating what you said, it's always a good idea to see what they did in the trials. In general, they have so much data to base those decisions on and clearly want to do things safely.
I'll just close with some really practical things. And I'm going to group the patients by Hem A, Hem B with or without inhibitors. Hemophilia B patients with inhibitors they don't have prophylaxis options. Using bypassing agents for prophylaxis is just too difficult, too challenging, too much treatment burden, and doesn't even really work well. So for hemophilia B patients with inhibitors who are older than 12, you now can and probably should be putting them on either fitusiran or concizumab. And once marstacimab has the indication, then marstacimab could be indicated for those hemophilia B patients with inhibitors older than 12. I really think that they should be on one of these drugs. You have to have a good reason not to put them on one of these drugs, or you're probably not doing the patients a good service. Hem B patients without inhibitors, we have factor products, extended half-life factor products. They're good. They work well. Patients have generally been very satisfied with them. They're good products, but they are IV. Most patients are on weekly IV, so that's 52 IV infusions a year. You still get peaks and troughs. And so for Hem B patients without inhibitors who are on a factor product, typically an extended half-life factor product, I think this is a good option for them and should be discussed. We always do the shared decision-making. How are you doing with your current drug? How's it working for you? Are you bleeding? Are you not bleeding? Is it difficult to administer? Is it not? That kind of discussion. And then to say, okay, we have other options for you. And you do have fitusiran, concizumab, and marstacimab for those patients without inhibitors as an option, and discussing the pros and cons of those with a lot of the information we provided here and more that you can find on your own, and then make a decision for those patients. I've had patients who have chosen to stay on the factor, and I've had patients who've chosen not to. For Hem A, it's a little more complicated because we have emicizumab. So for Hem A patients with or without inhibitors, if they're on emicizumab, those with inhibitors probably are. Many of those without inhibitors are also on emicizumab. Then the calculus is a bit different because they're already on a subcutaneous product. For concizumab, you're going to be giving more subcutaneous injections because it's daily, but it's with a pen, which is pretty easy. For marstacimab, you're going to give the same amount if it's weekly, or potentially more infusions, because most people on emicizumab aren't every 2 weeks or every 4 weeks, but it's with a pen. So it's pretty easy. And for fitusiran, that's where you've got the advantage of less frequent injections every 2 months, although you do need to get labs. For patients with Hem A, it's really, again, a shared decision-making approach. How well is the drug you're on working? These newer drugs, what can they do for you that the other drugs can't? Well, there's the pen, for example. There's the less frequent infusions for fitusiran. Those are all the things that come into mind as you're talking to your patients. And I think as you learn more about these drugs, as you know about the benefits, the risks, the implementation, the pens, the lab testing or not lab testing, I think that will help you to come to a rational decision that you can make for all of your patients. And the last thing I'll say is those decisions are dynamic. If you talk to a patient in clinic today and they decide they want to stay on whatever product they're on, when you see them again, whether it's in 3 months, 6 months, or a year, you bring up that discussion again because maybe they've changed their mind, or maybe we have more information to share with them. There's no point in the patient coming for a clinic visit just for you to say, hey, everything's great, you're not bleeding, here's your physical therapist checking you, and take off. This day and age, every single clinic visit, when we see a patient, every clinic visit, unless it's an acute bleed follow-up, it's a discussion about what do you want now? How's that working? Here are options for you that are different options. And really, that's what we do as doctors. We give the patients the different options, and then together we make a decision on what's best for them. So anyway, thank you all for listening. I hope it was a good learning for you. There's a lot more information out there, and we wish you all the best with all your patients.
Thank you, Drs. Weyand and Young, and many thanks to you, our listeners, for joining us today. As a reminder to view the full program, Clinical Focus in Hemophilia, integrating hemostatic rebalancing therapies into personalized, evidence-based patient care, please click on the link in the show notes. And be sure to check back regularly for more episodes on important hematology topics.